Hello again, it's Dr. Harim Jaffer. We will try to finish or continue on our lecture on the gingival disease in childhood. In the previous lecture, we talked about changes that are associated with normal development. But today we are talking about the gingival disease in childhood. Gingival disease in childhood includes two main categories. One of them is plug-induced or biofilm-induced, and the other one is the non-plug-induced. And both of them are the same, for example, in the adults as a category. So, in case of plug-induced gingivitis, we know that gingivitis is extremely common in children and adolescents, affecting up to 70% of children older than the age of 7 years of age. 7 years. Inflammation is generally limited to the marginal gingiva here, with undetectable loss of attachment and the alveolar bone. Although gingivitis doesn't always proceed to periodontitis, but we should know that every periodontitis will precede by gingivitis. So optimal oral hygiene care is important. Although gingivitis is highly prevalent in children, its severity generally is less intense than in adults. Similar oral hygiene conditions generally produce less severe form of disease in children compared to adults. At children's age, their tendency to develop gingivitis will increase. So with the aging process, the possibility of getting gingivitis will increase. The prevalence of disease is lowest during the preschool year and increase throughout childhood until reach its peak during puberty. Increases in gingivitis usually do not fully correlate with the amount of a plaque in childhood, suggesting the influence of the other factors, because we have, for example, crowding, we have exfoliating teeth, we have erupting teeth, sometimes we have calculus, so many factors are contributing here. Regarding the clinical features of biofilm-induced gingivitis in childhood, the most prevalent type of gingival disease in childhood is called chronic marginal gingivitis. The gingival tissue here exhibits a change in color, size, consistency, and surface texture similar to chronic inflammation in the adult. There will be red linear inflammation, which accompanied by swelling, increasing vascularization, hyperplasia. Bleeding and increased pocket depth are not found as often in children as in adults, but may be observed if severe gingival hyperplasia or hypertrophy will occur. Chronic gingivitis in children is characterized by loss of collagen in the area around the junctional epithelium and the predominance of the plasma cells and neutrophils. The presence of calculus deposits are uncommon in the infants and toddlers, but may increase with age. About 9% of 4 to 6 year old children exhibit calculus deposits, but by 7 to 9 years of age, 80% of the children present with calculus deposits. But by age of 10 to 15 years of age, there will be 33 to 43% of dental calculus formation according to the research. Within the category of special needs patients, children with cystic fibrosis have a higher incidence of number of calculus deposits, which may be caused by increased calcium and phosphate concentration in the saliva. So this is regarding the clinical feature and calculus. We have another term named eruption gingivitis, like you see here, the pseudocoronitis and eruption gingivitis. This is gingivitis associated with the tooth eruption which is so common that the term eruption gingivitis has come into common use nowadays. So, tooth eruption doesn't cause by itself gingivitis. However, inflammation associated with the plaque accumulation around the erupting tooth perhaps may be secondary to discomfort by wrong tooth brushing on the friable areas of the erupting tooth may cause gingivitis. The gingiva around the erupting teeth may appear reddened because gingival margin have not yet keratinized fully and the sulcus development is incomplete here. Exfoliating and severely carious primary teeth often contribute to gingivitis caused by plaque accumulation secondary to pain during brushing or food impaction in the area of tooth destruction. And we have puberty gingivitis. We discussed the puberty gingivitis in the previous lectures, and but we have a non-plaque induced gingivitis or non-biofilm induced gingivitis. Here we have primary herpetic gingival stomatitis, which also we discussed in the previous lecture, and we have candidiasis. Actually, candidiasis results from the overgrowth of Candida albicans, usually after a course of antibiotic or as a result of congenital or acquired immunodeficiencies. It's far less common in the child than in the adult, and it's rarely associated with the healthy child. Thank you for your listening. This is the end of this part.